Good afternoon, everyone. I welcome you all for this webinar on lung oligometastasis in operable oral cancer. So this is second in the series of the Expert Insight webinar series that we are conducting from Navya, with the help of TMC and NCG experts. So the intention of this Expert Insight series is to share the knowledge of the TMC and NCG experts with all the doctors who are interested in these topics, so that it will be helping them in implementation of these learnings in their clinical practice. So Navya is a cancer informatics and patient services company that leverages technology to provide personalized evidence-based cancer treatment plans. So we work with evidence-based engine, and there is an experience engine, and we also have the patient preference tools. The clinical data that is from the patient that is taken from the in the form of the data will be fed into the experience engine, the evidence engine, and the patient preference tool, which give out a structured clinical summary for the review by the experts, who in turn review the entire data for the clinical relevance and give their opinion on the next line of management. So this service is provided to all the cancer patients, irrespective of their location, their socioeconomic condition, and also disregarding where they are receiving their treatment. Next slide, please. So in this webinar on the lung oligometastasis in operable oral cancer, we have the expert from the head and neck disease management group of Tata Memorial Center. I welcome Dr. Laskar, the Professor of Radiation Oncology, Dr. Tyagarajan, Professor of Surgical Oncology, and Dr. Amit Joshi, who will be joining us shortly, Professor of Medical Oncology. Now I request Dr. Laskar to introduce herself and say a couple of words about her experience. Dr. Laskar, please.
Good afternoon, everybody. I'm Dr. Sarbani Ghosh Laskar. I'm a professor in radiation oncology at the Tata Memorial Hospital, Mumbai. And my chief site of interest is head and neck cancers. And I deal with the multimodality management of head and neck cancers in particular. And of course, in radiation oncology, I'm interested in conformal radiotherapy, the precision radiotherapy techniques, brachytherapy for surface lesions, and of course, even palliative radiotherapy. The topic that we are going to be addressing today is very interesting because there's a lot of upcoming literature and evidence to support, as well as a lot of ambiguity, as well as gray areas in the management of this particular problem that we have in head and neck cancers. And I'm looking forward to the interactive session. Thank you very much. Dr. Shiva, back to you. Over to you.
Yeah, thank you. So again, I'm looking forward to this session. My name is Dr. Shiva Kumar. I'm a head neck surgeon in the division of head neck, Department of Surgical Oncology, Tata Memorial Hospital, Mumbai. And an interesting topic, of course, nevertheless. And it will be interesting to listen to the comments of the various experts as we go forward. Thank you.
Already said by Dr. Sarbani and Dr. Shiva. So this is today's topic is a little bit newer and newer data are coming. So I think it's interesting to know the current concept or current state of the management for a oligometastatic head and neck cancer. So I think it will help us, all of us, in understanding this disease biology and managing the patient in a better way.
Thank you, sir. I welcome all the three experts for this webinar, and I thank them for sparing their valuable time for us and giving sharing their expertise and all that. So let me start with the introduction about the topic, and then we will go through a couple of cases which will be forming the basis for the expert to start discussing about the modality of management and care. So coming to the topic, there is limited improvement in survival rates for head and neck squamous cell carcinoma, especially in cases with distant metastasis. The metastasis can be simultaneous, synchronous, or it can be metachronous, which is reported to be between 4 to 24%. The most common sites are lung, bone, and liver, with leading metastasis to the lung around 70 to 85%. The management of metastatic patients is undergoing paradigm shift in oncology, as there is a lot of new data that is coming up with the research going on. So apart from systemic treatment, the local control of metastatic sites by local therapies like surgical resection, stereotactic radiation, radiofrequency ablation, cryotherapy, there are so many other methods which are being helpful in delaying the systemic treatment and also its consequent toxicity. But of course, determining the advantages or superiority of the approach and comparing that with the systemic therapy is challenging, because data is limited and now it is expanding further. So the experts are there to clarify which approach would be beneficial in which method, which kind of cancer and which kind of metastasis. So we will start with the first case. I'll just present the case in front of everyone, and then I would request the experts to take the discussion forward. So it is a case of metastatic oral cancer. It's a cancer of the maxilla. 62-year-old male tobacco user complained of a lump in maxillary region. It was reported in December 2016. He was a known diabetic and hypertensive on treatment. The CT and MRI of head and neck showed right hard palate soft tissue swelling and infiltration in the region of second and third molars. Submandibular, jugular, and a deep cervical lymphadenopathy was also noted. Histopathology showed malignant spindle cell tumor grade 3. IHC was negative for AE1 and AE3, P63, CK516, S100, HMB45, and desmin. Ka67 was 50%. The patient was treated with surgery, right orbital palate preserving maxillectomy, and right neck node dissection plus reconstruction was performed. The histopathology of the surgical sample showed malignant spindle cell tumor consistent with sarcomatoid carcinoma grade 3. The immunostatins for AE1, AE3, SMA, EMA, S100P, and HMWCK are non-contributory. MIB1 not satisfactory. Adjuvant radiation therapy was given to the primary targeted site. IMRT was given from March to May 2017. Then the patient was not on follow-up after the radiation therapy. He presented again with complaints of mild pain while eating, pain in the lower lip region extending to alveolar region in October 2020. A right lower lip excision biopsy was performed in November 2020, and the histopathology showed squamous cell carcinoma grade 1 with perineural invasion, skeletal muscle involvement, and WPOI score of WPOI pattern of 4. FDG PET-CT was performed, which showed post-surgical status in right maxillary alveolus. FDG avid mucosal lining nodular thickening of the reconstructed space, and right lower lip submucosal aspect. Low FDG avid few sub-centimeter sized left supraclavicular lymph nodes, the largest being 0.8 centimeter was present. Few soft tissue density bilateral lung lesions. The largest was in the right to right upper lobe of 1.7 into 1 centimeter, and right lung juxtamediastinal lesion of 1.8 into 1 centimeter, and 0.8 centimeter left upper lobe lung pleural nodule, pleural base nodule. There was no evidence of malignancy elsewhere. So there is a clear metastasis to the lung. So clinical staging, TNM staging was done as stage 4C, NET, NEN, and M1. Chemotherapy was started with carboplatin plus nab-paclitaxel for 2 cycles, and it was ongoing. The hematology, LFT, RFT, renal function test, cardiac function was adequate. Cardiac function was ejection fraction 60%. Then renal creatinine was 1.4. ECOG score was 1. So the patient came to us with with the question on next line of management. So this is the basis for the case, which I would like the expert to take forward and have the discussion and throw light on various modes of management and approaches for the case. Over to Dr. Amit Joshi, sir.
So I think in this case, the practically surgical option is practically out. I think Siva will agree with me. And since there are multiple sites of the disease practically the radiation role is not there. So if in this scenario, the treatment will be the either with the chemotherapy alone, that is the carboplatin paclitaxel has already been started. So we want to do further newer markers in the current era. In a metastatic head and neck cancer, we need to check for the specific marker on the tumor surface. That is what we call as a PDL1 with a scoring name as CPS, that is combined proportion score, CPS, which is a marker of the expression of the probable response for immunotherapy. So if the patient is affording, we may consider for doing a CPS scoring and adding the immunotherapy with the ongoing chemotherapy. So pembrolizumab is the current standard of care in this scenario. However, the overall intent, that means the adding immunotherapy to the chemotherapy, there is a definite improvement in the survival of this patient, but that survival is still not, addition of immunotherapy will not going to totally eradicate the disease from the body. So the intent will still remain palliative, but definitely the quality of life and the longevity, what we call as overall survival, definitely has improved with the addition of the chemotherapy with immunotherapy, especially if the CPS score is on the higher side. And the patient is not affording, then we may continue with the same chemotherapy regime for 3 cycles and then see the response in the PET-CT. If they are responding, we can consider up to 6 cycles of chemotherapy total. And the other option is if the patient is not fit for chemotherapy, then the oral metronomic chemotherapy, which we very commonly use in Tata Memorial Hospital, we can consider for going with the oral metronomic chemotherapy. And there is a recent data from the Our Institute that lower dose of immunotherapy can be combined with immunotherapy, so the cost overall will come down. But I don't think so that the intent is still will be remain palliative with the improvement in quality of the life and the longevity with the with whatever we can achieve with adding newer therapies. I think Dr. Sarbani can also add in this.
Yeah. So I just want to know one thing. This PET-CT that you're showing now is November 2020.
Yes,
And
ma'am.
when was the lower lip lesion excised?
It was in November 2020 only.
So based on this, because that was a lower lip excision biopsy, and at the same time, if the PET-CT is showing this finding of nothing being there at both the upper alveolus as well as the lower lip, but is talking about some non-specific left supraclavicular nodes and these lesions in the lung, I think this would be oligoprogressive metastasis rather than just oligometastatic disease, because the point is that this patient in no time has actually had these metastatic lesions. So this patient would actually fall into the group of patients who would have a poor prognosis and poorer outcomes. So just because the general condition is good and does not seem to have any widespread metastasis, I would agree with what Dr. Amit Joshi is saying. And essentially, most of the treatment in this patient would be symptom directed. Of course, based on response, we would take the next steps in this patient, because if this patient cannot afford, and we are going to continue with carboplat plus paclitaxel, and if he cannot even afford the extreme kind of regime, I think it is just a matter of giving the patient something that he would be responding to, right, Amit?
Yes, ma'am.
And it will have to be, this is going to be really a palliative kind of situation, because you said November 2020, it was excised, which was essentially an excision biopsy. And at the same time, the PET-CT is showing these findings. So he hardly has any disease-free interval considering the second cancer.
So I would just say one line that there's no role for surgery in this situation, and the intent remains palliative. And I agree with what Dr. Amit Joshi and Dr. Sarvani is saying regarding for this.
Okay, sir. So shall we move on to the next case?
I think the only thing we could have done differently, if there is a solitary lung metastasis, then definitely we need to find out whether it was the recurrence of the it is the same malignancy, or rarely the lung cancer can manifest, which might have a different treatment protocol. And if theoretically possible to go for a surgery or go for a SBRT, then things would have been a different direction. Since the both lungs, bilateral lung is involved, I don't think so that we can target with any sort of a local therapy in this scenario.
Yeah. So the only thing I would like to add here is that if this patient would have come to us with these lung lesions, I just would want to make sure that they are met, in the sense that based on the PET scan, and based on the SCV value, and probably we'll have to discuss this with our nuclear medicine colleagues, and make sure that it is a metastatic lesion and not something else. In a country where there is a high incidence of tuberculosis, we have to keep that in mind, and we just have to know that this is metastatic. And when we are calling it palliative, we need to be sure that it is palliative and we are not missing out on something. That is the only point I would want to reiterate here. And if necessary, maybe CT guided biopsy of target biopsy of the most suspicious lesion to establish a diagnosis of metastatic disease, and make the intent palliative, and of course go ahead with treatment that has been mentioned. That's the only point I'd like to mention.
Yes, sir. I think rightly said that tuberculosis is something that will be a differential diagnosis in this scenario. And moving on to the next case, I think that is the second case is of cancer of the tongue. 77-year-old male who is a regular tobacco and alcohol user complained of painful ulcer in the right top side of the tongue on October 2019. He was a known diabetic and hypertensive on treatment. On examination, an ulcer on the lateral border of the tongue, about 1 centimeter in size with the indurated edges, was found. Ulcer cytology showed severe epithelial dysplasia. Ulcer on the right lateral border of the tongue cytology showed severe epithelial dysplasia in October 2019. Biopsy was done, that is wide excision biopsy of the ulcer of the tongue was done in October 2019. The histopathology showed a tumor of 2 centimeter by 2 centimeters and surgical margins were negative. It was a squamous cell carcinoma, invasive keratinizing type, cancer grade 1. Pathological TNM staging was done as stage 1, T1, NX, MX. No adjuvant treatment was taken and patient was on liquid diet. Second presentation was in July 2020. Patient came with complaints of swelling in the right side of the neck, submandibular swelling for 4 months. Did not consult doctor due to lockdown. FNAC of the right neck swelling was done, which showed signs of metastatic acinomatous deposits, probably of squamous cell origin. CT scan of the neck showed no obvious enhancing lesions in the tongue. Enhanced necrotic lymph nodes with peripheral rim enhancement noted in the right submental, right submandibular, and right parapharyngeal regions. Largest one was measuring 2.7 into 2.3 centimeters, a possibly metastatic lymph node. Well-defined pleural base nodule in the left lung. That is again a possibly metastasis. It was found in July 2020. So staging was done as stage 4, NET, NEN, M1. Hemogram, heart and liver function test data is not available. Renal function was adequate, creatinine 1.25. ECOG score was 0 to 1. Question was on the next line of management.
So definitely for this patient, I would go on to do a PET-CT, because it is important that I establish what is the extent of disease in this patient, because the disease-free interval is actually only 9 months. From the surgery in October 2019 to July 2020, 9 months, the patient has had a nodal recurrence, as well as the CECT shows that there is at least one pleural-based nodule. So I would go on to do a PET-CT to know the extent of disease. And thereafter, of course, you've already done an FNAC, and if there is more disease than is evident on the CECT, I would then decide accordingly about the further line of management. So the next step would be a PET-CT, definitely.
So now we do not have the PET-CT. So considering the CT neck and the nodule in the left lung, if we consider that only the metastasis is in the lung, and then if we go for the management, being a solitary nodule in the lung, so I think maybe we can take the discussion forward in this approach.
So if I may say, is it okay? Yeah, Amit or Shiva, you want to say something?
Yeah, no, please go ahead.
Yeah, so now this is a case in which he's got a local recurrence as well as a regional recurrence as well as possibly lung mets. Now, the point is that I think in this place, I would also like to histologically establish the lung metastasis, because that will be important for me to decide whether I want, how aggressive I want to be about treatment. Now, supposing that pleural nodule is positive, my intention will actually be that I treat the necrotic lymph nodal metastasis as well as the lung mets. Now, if you ask me, is there definite data, level 1 evidence? No, there isn't. Most of the level evidence is either level 2 or 3. And what I would like to do in this case is, you have very small data, and most of them are from also from what you call SEER databases as well as from the NCDB analysis. But what they do show is that if you could treat limited metastasis aggressively, you could possibly get other better outcomes. But the other problem with this patient is that he's 77 years old with diabetes mellitus and with hypertension. So we have to kind of weigh what would be best for this patient. So there are two options I could think of. One is, would Shiva like to do any kind of surgery for the lymph nodal metastasis? Because you also talk about parapharyngeal disease, the lymph nodal mass going into the parapharyngeal region, which simply means that we'll have to see the scan properly and whether that is amenable to resection or not. If it is not, in this elderly gentleman, I would ask Amit whether he would consider any kind of systemic therapy. If it is amenable to systemic therapy, I would start with systemic therapy and then give local consolidative radiotherapy. But at the same time, if this disease is causing symptoms, especially the large nodes in the neck, I may also give radiotherapy to start with. So it's very important in this kind of a situation to actually see the patient, see his comorbidities, see what is the major symptom in this patient, and then accordingly proceed. That would be my take on this particular patient.
Yeah, so agree with what Madam said, but just to add a few more points, is that we just need to characterize the lung lesion, and also depending on whether it is metastatic or not, and what is the size of the lesion. Usually, when we see any lung lesion which is less than 1 centimeter, our radiologists say it is indeterminate, and they have to characterize it. And if it is less than 1 centimeter, it's difficult to get a biopsy as well. So that we probably will have to take a call and give the benefit of doubt to the patient, depending on what is the characteristics of the nodules, how many nodules are there, what was the the TNM staging of the disease presentation, all that will be factored in. And we need to be sure about that. The second thing is about the disease in the neck. We definitely need to see the scans and need to see whether it is resectable or not. But then going by the clinical picture that is just being presented, I think he's definitely not a surgical patient. Presuming that it is a metastatic lesion that is being said. So just completion, I just would like to say a few words about metastatectomy in head and neck squamous cell carcinoma per se. So metastatectomy was done way back in the turn of the 20th century, close to the first metastatectomy that was done many years back. But then people have burnt their fingers and realized that it's not probably worth that going ahead with that surgery. One, because it's morbid. It's a systemic condition now. It's no longer a loco-regional disease. Just doing this and just removing what is visible to the eye will not work. And the other thing is there are various modalities which have come up over the years in be it newer radiation techniques or newer drugs in the form of immunotherapy. So surgery definitely has a very, very, very limited and minuscule role as far as a metastatectomy is concerned in this situation. there are few series, hardly a few patients. Then maybe a few patients who have undergone metastatic seem to have better than those in thin. But then that has to be taken with a pinch of salt. What kind of patient they chose for that is all you have to look into the detail. So metastatectomy is not a thing that is to be offered on a routine basis. We even think of metastatectomy when it's oligometastatic, meaning a few metastases. Usually, generally, it is described as less than 5 or even single or not more than 5 metastases, anyways, and a single organ involved. If it is multiple organs that are involved, again, it's not the patient is not a candidate, and especially in head and neck squamous cell histopathology, squamous cell carcinoma patients definitely candidates for metastatectomy. So these are the points that I would like. And if at all anybody considers a metastatectomy, it may be useful only if you achieve an R0 resection of the metastasis that you're looking at. If it is R+, that may not benefit the patient. And also it has been seen if it's a primary coming from oral cancers, those patients also don't seem to benefit. And the disease-free interval from the primary treatment, if it is less than 1 year, again, those don't benefit. So if at all in the small, rare subgroup, if you're considering metastatectomy, you need to look at that. But said that, metastatectomy in a head and neck squamous cell carcinoma is a rare injury. Thank you.
I think I agree with both of you, Dr. Siva and Dr. Sarbani. The other thing which sometimes aids in decision making is the because we know that the oral cavity lung metastasis vis-a-vis the metastasis from a oropharyngeal lesion. So those lesions which are HPV positive, theoretically their prognosis is somewhat better compared to the patients of an oral cavity tumor. So in general, oral cavity tumor metastasis, they do poorly compared to the oropharyngeal lesion. And in among oropharyngeal lesion, if the primary was HPV positive, then the possibility of response to the second line therapy, either SBRT or a chemotherapy, is definitely better. So as discussed by Dr. Siva, that this field is evolving. Similarly, the number of lesion. So if it is less than 5 and all lesion can be targeted with radio SBRT, the disease, primary disease is well under control, then definitely theoretically we can consider for doing an SBRT to all those lesions if it is amenable. And in this scenario, there are various trials are currently ongoing to look whether the in a metastatic condition, how many number of metastatic site can we treat, and it is ultimately going to give the benefit to the patient or not. We may amenable for the lesion may be amenable for local treatment, but whether that local treatment is going to benefit the patients in terms of quality of life or survival, there is data evolving in this scenario. Till the time, if less than 5 in number, the DF5 period more than say 1 year, then we can, and the oropharyngeal primary with which are HPV positive, and definitely nasopharyngeal is entirely different, so we will not discuss here. But the oropharyngeal cancer can be considered on case-to-case basis for the primary treatment.
Just one thing that I'd like to say is, in this patient, if we are considering this lung pleural-based nodule as metastasis, this would actually fit into that scenario of synchronous metastatic disease, though it is oligometastatic. So I think the point is that if in such a patient, if he's in good general condition and he's suitable for chemotherapy, I, as a radiation oncologist, may like to start off with, and he's not very symptomatic for the regional disease, I may want to start off with systemic disease, and then depending on the response, actually consolidate the response with local RT at the regional site. Now, in this condition, whether we should be doing SPRT for the distant metastasis is again something that is a matter of debate, because we really don't know about how good. The situations that Shiva and Amit have actually alluded to are more of the oligometastatic site where the locoregional disease is controlled, and you have metastasis coming up in different sites, usually less than 5, which is considered as oligometastatic. But in this situation, which is a synchronous metastatic disease, we may want to start off with systemic therapy and then consider consolidative therapy to kind of consolidate the response attained to chemotherapy. And if and especially patients who do good and respond well to the chemotherapy will also do good in the long run as compared to people who will not do well. And if there is a good response to systemic therapy, it is actually worthy of being treated loco-regionally, simply because in those patients, the outcomes are actually better than patients who don't have a response or who do not receive local therapy, but only receive systemic therapy. Again, the evidence here is not level 1 or randomized trials, but from various databases and from general population-based studies, So we have to remember that because this is synchronous, we may want to start off with systemic disease, again, in an attempt to palliate as well as to kind of prolong survival as maybe worthy of this patient, because we have to keep in mind that he's 77. I'm just a little worried as to what he's going to be able to tolerate.
So, ma'am, what are the modes of we in the introduction we were talking about the cryotherapy, stereotactic radiation therapy, and all that. Like, what would be the role of those kind of like?
So here in this particular case, we will not talk about stereotactic radiotherapy, because here what we are going to encompass is the local disease, the regional recurrence that has happened, which is at the lymph nodes in the neck. So there are studies in radiation which talk about advanced disease, and they're doing just no elective volumes, but just treating wherever there has been a recurrence. We could treat that with hypofractionated radiotherapy or with conventionally fractionated radiotherapy, but we have to try and give a dose of more than 60 gray to be able to prolong the control because of radiotherapy. But in this case, we will treat the neck nodes. We are talking about treatment to the regional recurrence and not to the lung metastasis. Then in due course, if you're able to control, and if there is further good response, we may consider doing SPRT or SRT for the pleural metastasis. But just now we are talking about covering the lymph nodes in the neck because they are the ones that will cause problem in due course.
Dr. Tyagarajan, can you add some notes on the surgical management? Like, if at all, if we have to go for a surgical resection of the solitary nodule in the lung, like what are the methods to be adopted, or what is the approach? How best we can manage the case?
So, I wouldn't be able to comment on the method of the section for the the lung lesion, because it's usually done by a thoracic surgeon. I'm a head neck surgeon. So usually, if at all we need to get a metastatic to be done, we would refer it to our thoracic surgery colleagues. But having said that, I was just having a word with our thoracic surgeon colleagues incidentally yesterday about metastatectomy being done by them in their series of over more than 10 to 12 years. And they were telling out of the maybe in their series of over 400 plus metastatectomy, which they usually do for other sites. But then the number of patients with head and neck squamous cell carcinoma in their series of more than 400 patients was hardly 10 to 12 patients. So that tells every one of us that the indications for a metastatectomy in an head and neck squamous cell carcinoma is almost remote. Maybe those 10 to 12 patients that were referred for a particular reason. We really don't know. We have to go back and look into it. What are the reasons that we referred them to them? So, I mean, the point here is not the technique of metastatectomy. The point here is whether we need to refer these patients for a metastatectomy, right? For those patients. So there are hardly any patients now with the, with the technique. I mean, with the immunotherapy that's come up in a very big way. So I think we have to, of course, cost being the, the limiting factor. We have other techniques to, treat these patients, and surgery definitely comes way down the list, and maybe for a very few selected patients, and not to be considered for, as the, one of the frontal things for a metastatic lesion, even if it is solitary. Even if it is solitary, it is just at the surface. It's a systemic. So we need to take care of that situation accordingly.
And the other place in this particular case, surgery will really be much lower down on the list because the primary disease itself is not controlled. The patients whom we've sent for a metastatectomy are oligometastatic disease where the locoregional disease is controlled. In this patient, he's got a regional recurrence with a metastatic disease. So definitely this patient doesn't go for a surgical thing, because a thoracic metastatectomy in such a patient, we have to think about the morbidity of surgery also. And then what are the outcomes going to be? Now, supposing this patient didn't have this regional recurrence and only had that solitary metastatic disease with a long DFI, you may have considered doing some form of surgery. But in his present situation, I don't think surgery would be something that would be considered upfront. Right, Shiva?
Yeah, absolutely. I agree with that. So metastatectomy, I mean, is being done for other indications, like for sarcomas, for bone tumors, which lung mets, those are different indications altogether. Now, that apart, head and neck squamous cell carcinoma, at least I personally have not referred any patient for a metastatectomy. I've never done that in my practice, but maybe other colleagues of mine might have done. But even that is the number over 10 years is hardly 10 to 12. So those are highly, selected patients for maybe a specific indication. If we look into the case, we'll understand that. So the point I want to drive home to the listeners is that metastatectomy for head and neck squamous cell carcinoma is a rare thing, and it has to be way lower down in your list, and maybe for a highly selected, kind of patient, because you have better alternatives, right?
Dr. Joshi.
Yeah, so I think regarding the technique, if it is very peripheral located, then they can go ahead with wedge resection of that area. The other important thing before metastatectomy, for thoracic surgeon, they need to localize. If it is very tiny, it can't be palpated. So they have to palpate at the time of surgery. So if it is tiny, less than 1 centimeter, they are not able to exactly locate and remove. So lesion should be of that much size, so it can be palpable at the time of metastatectomy. If it is peripheral, it can be considered from a wedge resection by a video assisted technique. If it is in the deeper part of the lung, and as discussed, the patient has a long DFI, single site of disease, then a lobectomy can be considered if we feel that removing a lobe of lung in this patient will give him a better long-term survival. But as discussed by Dr. Siva, head and neck, in a head and neck cancer metastatectomy, we rarely encounter such situation, because most of the time they present with the multiple metastatic disease that might have gone to the liver also, multiple site of lung also. Even if it comes out to be solitary lung lesion in a head and neck cancer, we have to prove whether it's a squamous cell carcinoma or it may be a second malignancy like a lung cancer rather than the metastasis from the head and neck cancer. And with the availability of the other newer modalities of treatment like the immunotherapy, the targeted therapy like cetuximab-based chemotherapy, the survival which was only with surgery, the same survival can be achieved with these newer therapies, provided the patient is affording for this. So the use of metastatectomy is not very, very common in metastatic headache because of all those obvious reasons. And we know in our country, the oral cavity is one of the most important, the #1 cancer, and the prognosis of that oral cavity cancer is dismal. In oropharyngeal cancer, there is some good data that even those group of the patient may respond to some local treatment like a metastatectomy or a SBRT.
Thank you, sir. Now we will move on to the question and answer session. The users, if you have any questions, you can please post it in the chat box, or you can raise your hand so that we can unmute you. And so there is one question. I'd like to understand, how does the disease-free interval affect the decision making in the management of oligometastatic head and neck disease?
So the disease-free interval is actually a surrogate for the biology of the disease. If you have a longer disease-free interval, it simply means that this cancer is essentially a biologically better disease to treat prognostically. And the other thing that is important in addition to the disease-free interval, and which has been alluded to during the discussions, is the location of the primary disease. Oral cavity versus oropharynx versus hypopharynx. and the disease-free. So you cannot take only one parameter in isolation, but yes, a longer disease-free interval simply means that the biology of the disease is more favorable than otherwise. And also it gives you that time interval for you to be able to treat more radically than if the disease-free interval was shorter.
Thank you, ma'am. Anybody else? Any other questions? Can you please post the question here? I think we do not have any more questions that needs to be answered with the kind of discussion we had. I think everybody got the answers to the questions they had. So I believe that we won't be having any more questions that needs to be answered here. So I would like to take it to the next step. I would request each of the panel member to give a take-home message on the entire as a summary on this topic, and then we can go to the next step. So, Dr. Laskar, you can please start.
So what I'd like to say is that when a patient with oral cancer, I'm talking only about oral cancer in the head and neck site, presents with metastatic disease, it is very important for us to categorize the kind of metastasis. That is, whether it is synchronous versus metachronous. Even when it is synchronous or metachronous, we then need to know whether in the synchronous setting, it is oligometastasis or polymetastatic disease. In the metachronous situation, we again need to decide whether it is oligometastatic, oligorecurrent, or oligoprogressive, because these three entities decide how you are going to approach a particular case. In addition, we need to look at the general condition of the patient, comorbidities, the disease-free interval, and the site of metastasis. Lung metastasis or oligometastatic lung disease actually does better than metastasis to the bones or to the lungs or to the liver. So we need to remember these things. So we need to ascertain the status of the locoregional disease and know what is the volume of the metastatic disease, and then approach the patient, and the intent of treatment depends on these parameters. Thank you.
Dr. Shiva?
Yeah, I just would like, I think I agree with whatever Madam said, and just to add that, just to again underline that the role of metastatectomy in head and neck squamous cell carcinoma is very limited, where for a highly selective, in patients, individuals. So because there are various, better treatment modalities that have come up years, so which are non-surgical. So essentially, role of surgery in this kind of situation is very limited. Thank you.
I think both Dr. Siva and Dr. Sarbani has very well summarized. The other thing, in some cases, we need to see life expectancy and other comorbidity. Like in a previous patient at year with a very comorbidity, how much benefit we are aiding, and the morbidity of this treatment we are planning. Suppose if we are planning a metastectomy, patient is having underlying a COPD, lung conditions are already bad, diabetic patient, the patient can land up in a post-op complication and will not achieve what we want. So apart from this, we have to see other and the other like cardiac status, the renal condition. So this is usually a multifactorial decision. And as told by Dr. Siva, it's not very common. We rarely in a year, hardly 1 or 2 patients, very selected patient, we send for an operable head and neck, at least the oral cavity cancer. This is not very commonly practiced because of the issues which we have discussed. So in a joint clinic or multimodality clinic, if we feel that the patient can get some benefit with the aggressive treatment of the metastatic side, with all the points which is highlighted there, lung only disease, less than 5 in number, amenable for treatment, long DFI period, then we can consider for a local therapy either with SBRT or a metastectomy.
Thank you, sir. I think this is, as all of you highlighted, this is one of the rare cases that we are finding in the clinical practice. But this is one of the things which is lacking much of data, where the decision making in the clinical setup is very challenging. So the oncologists with whom we are working, who are referring cases, they have these confusions, and they wanted some more clarity on certain aspects of management. And I think the data that you have reviewed and you have presented here, I think it will be going to be helpful to them in their clinical decisions. And I hope Navya will be able to give better opinions on such kind of cases with your guidance and help. And the oncologists will be benefited by this series of expert insight, and especially this webinar on the lung oligometastasis in operable oral cancer. With this, I would like to thank you all for sparing your valuable time and giving us the time for sharing your expertise, experience, and knowledge with all of us, and giving the guidance to us and helping all of us in knowing better about the nitty-gritties of the management of head and neck cancer. I thank you, ma'am, and thank you, sir, Dr. Tyagarajan, and Dr. Joshi, and Dr. Laskar. I thank you all for your time, and I thank all the participants for your time for attending this webinar. There is a questionnaire that will be coming to you as a feedback questionnaire. Once you leave the webinar, please answer that. And if you have any questions which comes to your mind after leaving, you can just put it across in that feedback form so that we can get back to you with the response to those questions with the help of the experts here. And with this, I would like to conclude the session. And I thank you all once again for your time and participation. Thank you, sir.